Hello, everyone, and welcome to our second module on antihypertensive drugs. We'll start this video by discussing drugs that disrupt the renin-angiotensin-aldosterone system, otherwise known as the RAS. And so before we do this, let's briefly review how the RAS functions. So recall that angiotensinogen is produced by the liver, and it's always floating around in our blood. When the kidneys sense low blood pressure, they can release renin into the bloodstream. Renin will convert angiotensinogen into angiotensin 1, and then when angiotensin 1 gets to the lungs, it will encounter an enzyme called ACE, or angiotensin converting enzyme. This will turn angiotensin 1 into angiotensin 2. And then angiotensin 2 is really the workhorse of the RAS. It has a number of effects that raise our blood pressure. For one thing, it can activate the sympathetic nervous system. It also tells the kidneys to reabsorb more sodium and chloride and therefore water. It also causes arterial or vasoconstriction directly. It can stimulate aldosterone release from the adrenal glands, and it can stimulate ADH release from the pituitary gland. And so all of these effects, which I've shown here on this slide, have the net result of increasing salt and water retention, raising the amount of fluid in the vascular system, so that raises the preload, also raising the afterload by causing vasoconstriction, and therefore all these effects conspiring to increase the blood pressure. So basically, the RAS works together with your sympathetic nervous system to keep your blood pressure up and to keep the blood pressure normal. So in this video, we'll talk about three groups of drugs that disrupt the RAS to bring down the blood pressure. One group are the angiotensin receptor blockers. They block the effects of angiotensin 2. Another group are the ACE inhibitors. They block the enzyme ACE so that A2 won't get produced in the first place. And then finally, there's a drug called aliskiren, which is rarely used, but it's basically a renin inhibitor, and we'll talk about that as well. But the bottom line here is that all these groups of drugs disrupt the RAS with the goal of lowering the blood pressure. Let's start by talking about the ACE inhibitors and the angiotensin receptor blocker drugs. So ACE inhibitors have names that end in pril, like captopril and enalapril and lisinopril and ramipril. And the angiotensin receptor blockers, or the ARBs, have names that end in sartan, like candesartan and irbesartan and valsartan. And these two groups of drugs, because they disrupt the RAS, have some similar side effects. So first of all, both ACE inhibitors and ARBs can cause hyperkalemia. This is because these drugs decrease the release of aldosterone from the adrenal glands. And one of the things aldosterone does is promote the excretion of potassium in the urine. So when you block the effects of aldosterone or decrease them through one of these groups of drugs, you're going to get less excretion of potassium in the urine, and that could potentially lead to hyperkalemia. And then secondly, both of these types of drugs can potentially cause renal failure by lowering the glomerular filtration rate. The way you can think about this is anytime you lower the blood pressure, you lower the driving force for blood into the kidneys. And so if you do that too much, you won't have enough blood flow into the kidneys, you won't have enough blood getting filtered, and essentially you will develop renal failure. And that can occur as a side effect of many antihypertensive drugs, but especially the ACE inhibitors and the ARBs. For your STEP exam, it's super high yield to understand how the different RAS drugs will affect the circulating levels of renin and angiotensin 1 and angiotensin 2. So let's talk about that now. So ACE inhibitors are going to block the enzyme ACE. That's going to decrease the amount of angiotensin 2. That's why these drugs work as antihypertensive medication. But when the blood pressure gets lower, the kidneys are going to release more renin, and that's going to convert more angiotensinogen into angiotensin 1, so the angiotensin 1 levels will go up. And so I've summarized these effects on this table here. ACE inhibitors increase the renin level, increase the angiotensin 1 level, and decrease the angiotensin 2 level. They should have no effect on angiotensinogen because that is released by the liver constitutively. Angiotensin receptor blockers, on the other hand, are going to block the effects of angiotensin 2 so that none of these things happen. But once again, when the blood pressure gets low, the kidneys are going to release more renin. That's going to generate more angiotensin 1, and ACE is still functioning normally, so that will generate more angiotensin 2. So I've shown these effects here. When you give an angiotensin receptor blocker, you should expect higher levels of renin, higher levels of angiotensin 1, and higher levels of angiotensin 2. And this table here is super high yield stuff to know for your Step 1 exam. Let's talk briefly about bradykinin, which is a protein found in a number of places in the body, and it's responsible for some important side effects of ACE inhibitor drugs. So remember that ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2, and this is why they're helpful for lowering the blood pressure. But ACE inhibitors also block the breakdown of bradykinin into inactive metabolites. So patients taking ACE inhibitor drugs will have an increase in bradykinin levels, And this is what's responsible for two important side effects of ACE inhibitor drugs. The first one is a cough, and the second one is peripheral vasodilation. So about 10% of patients who take an ACE inhibitor will develop a nagging dry cough. And this is the reason why many patients who take these drugs have to have them discontinued. The feared side effect of ACE inhibitors is angioedema. This is caused by vasodilation related to bradykinin. Patients can develop swelling of the face and tongue. This is a picture of a girl with angioedema around her eye. And if the swelling involves the throat, it can cut off the airway and potentially be life-threatening. Luckily, this is a very rare side effect of ACE inhibitors, but it is the feared side effect of these drugs. And both of these side effects, dry cough and angioedema, are related to high bradykinin levels. They generally don't occur with angiotensin receptor blockers. They're very, very rare with those drugs. So usually if a patient has a dry cough on an ACE inhibitor, they're switched to an ARB. And then the final angiotensin disrupting drug we'll talk about is aliskiren. Aliskiren is a direct renin inhibitor, so it blocks the ability of renin to convert angiotensinogen into angiotensin 1. So when this happens, angiotensin 1 levels will fall, and therefore angiotensin 2 levels will fall. But once again, the kidneys will sense the fall in blood pressure caused by less angiotensin 2, and they will release more renin, so renin levels will go up. And so these effects are summarized right here. This is what you would expect to see in a patient taking aliskiren. In the renal section, I have an entire video on diuretics, so I won't discuss these drugs in detail here, but I'll just mention that all diuretics remove blood volume, so they lower the preload to the left ventricle, and therefore they lower the cardiac output. So all diuretics will reduce the cardiac output and therefore reduce the blood pressure. So for example, loop diuretics, like the drugs listed here, all lower the blood pressure. So do thiazide diuretics. In particular, hydrochlorothiazide and also chlorthalidone are sometimes used to treat hypertension. These are mild diuretics, so they won't produce a lot of volume loss, but they will lower the blood pressure slightly. And then finally, potassium-sparing diuretics, like all the drugs listed here, also lower blood pressure. Okay, next let's talk about hydralazine. Hydralazine is an antihypertensive that works as a direct arteriolar vasodilator. Its exact mechanism of action is actually not really understood, even though it's a very old drug. What is known is that it causes arteriolar vasodilation through some mechanism, and that lowers the peripheral resistance and therefore the blood pressure. It can be used to treat hypertension, although this is rarely done. It's also sometimes combined with nitrates for treatment of heart failure, although this also isn't commonly done in the modern era. One of its claims to fame is that it can be used in pregnancy. And then another thing that's high yield to know about this drug is that it potentially causes a drug-induced form of lupus. So lupus is an autoimmune disorder that I talk about in detail in videos in the immunology section, but here I'll briefly review drug-induced lupus, which is a clinical syndrome that is similar to traditional lupus. So patients can develop a malar rash like what's shown on the slide here. They can have arthritis, they can have low blood cell counts. Usually it's milder than traditional lupus, and usually there's no associated renal failure or central nervous system disease. The key finding, and this is what you want to know for board exams, is that antihistone antibodies are commonly elevated in patients who have the drug-induced form of lupus, and they're not commonly elevated in patients who have the traditional form of lupus. There are a number of drugs that have been associated with the drug-induced form of lupus, but the three classic ones are hydralazine, which we're talking about here, procainamide, which is an antiarrhythmic drug, and isoniazid, which is used to treat tuberculosis. Next, let's talk about drugs used in the treatment of hypertensive emergency. So in the video on hypertension, I talk about hypertensive emergency, which is when the blood pressure gets very high and it causes symptoms like headache and chest pain. And when we're treating hypertensive emergency, we use unique drugs that are intravenous and rapid acting so we can quickly bring down the blood pressure, but also control the blood pressure by turning the drugs on or off. One thing you need to be aware of when you're treating hypertensive emergency is that if you lower the blood pressure too fast, this can cause ischemia of tissue beds. So to understand this, let's imagine we have a capillary inside of an organ in the body, and before that capillary there's an arteriole. Well, if the blood pressure gets very high, let's say it gets to be like 200 in someone with hypertensive emergency, this would drive so much blood flow into the capillaries. It's too much blood flow, so autoregulation will occur and tissue beds will vasoconstrict these arterioles to try and keep the blood flow normal into the capillary beds. Well, now think about what happens if you rapidly turn this 200 blood pressure into a mean pressure of 100. The arterioles won't have time to react. They'll remain vasoconstricted, and you'll get a sudden drop in the perfusion to tissue beds and capillaries, and this can cause ischemia of organ systems. And so this is why when you bring the blood pressure down in hypertensive emergency, you do it slowly. And I've summarized these points here. Autoregulation of vascular beds leads to vasoconstriction when the blood pressure is high. So if you lower the blood pressure too rapidly and this vasoconstriction remains, you'll suddenly have poor blood flow and ischemia of organ systems throughout the body. One of the drugs used to treat hypertensive emergency is nitroprusside. This is a short-acting intravenous drug. It raises the intracellular levels of cyclic GMP in smooth muscle tissue, and that causes the release of nitric oxide, and nitric oxide is a powerful vasodilator. So as a result of giving this drug, you get smooth muscle relaxation in the venous system and the arteriolar system. In the venous system, when you dilate veins, blood pools in the venous system, less blood goes to the heart, so you lower the preload and the venous return, and this lowers the cardiac output. When you vasodilate arterioles, you get a decrease in the afterload on the heart. So both of these effects work together to lower the cardiac output and the TPR, and that will lower the blood pressure. Because the drug is intravenous and rapid acting, it's useful in hypertensive emergency. The important thing to know about this drug is that it can cause cyanide toxicity. This is its structure right here, and can you see it has all these cyanide molecules attached to it? So basically these can be released and the patient can develop cyanide toxicity. And in the biochemistry section, I talk about cyanide, but it inhibits electron transport, and so it can lead to lactic acidosis. So potentially a patient who is on nitroprusside for too long can develop lactic acidosis. That's going to present with a decreased bicarbonate, that's the acidosis, and high levels of serum lactate. It's high yield to know that a patient with a prolonged infusion of nitroprusside can develop this serious complication. Another niche drug sometimes used in hypertensive emergency is phenoldiprem. Phenoldiprem works as an agonist to the D1 subtype of dopamine receptors. And when you activate this subtype of dopamine receptor, you get some unusual systemic effects. First of all, you get arteriolar vasodilation, so this will lower the peripheral resistance and therefore lower the blood pressure. But also when you activate the D1 receptor, you increase blood flow to the kidneys, and so therefore the kidneys filter more blood and produce more urine, so you increase urinary sodium and water excretion. So this drug's sort of claim to fame is that it maintains renal perfusion through this effect while vasodilating through this effect. Other drugs that are peripheral vasodilators can lower the blood pressure so much that you underperfuse the kidneys and cause potentially renal failure, but that's less likely to happen with phenoldiprem because of this effect right here. On this slide, I've listed some other drugs that are used in hypertensive emergency. All of these drugs can be used because they're intravenous and rapid acting. So labetalol is a beta-1 and alpha-1 blocker. Esmolol is a rapid-acting beta-1 blocker. And nicardipine and clofidipine are intravenous forms of dihydropyridine calcium channel blockers. Let's talk briefly about orthostatic hypotension, which is also called postural hypotension or orthostasis. And basically all of these sort of confusing terms here refer to a drop in blood pressure due to gravity when a person goes from lying or sitting to standing. Anytime we stand up, gravity pulls blood volume down towards our feet and away from our heart, so we get a drop in cardiac output and a drop in blood pressure. But normally this is counteracted by the sympathetic nervous system. That's why we don't all get dizzy when we stand up. The sympathetic nervous system has a number of effects. It increases the venous return and the cardiac output. It raises the heart rate. It raises the total peripheral resistance. And all these things prevent us from having a severe blood pressure drop when we stand. But this sympathetic nervous system reaction to standing is impaired in a couple of situations. It's impaired anytime blood volume is low. Those people can have a severe drop in blood pressure on standing. It's also impaired in patients with low TPR who have a lot of vasodilation, and anytime there's blunting of the autonomic nervous system, including the sympathetic system. So when these kind of things are going on, patients can stand up and have a severe drop in blood pressure. And anytime the drop is greater than 20 millimeters in systolic blood pressure, that's the definition of orthostatic hypotension. And when there's this much fall in blood pressure, patients can develop dizziness or rarely syncope. So what are some of the common reasons that patients develop orthostatic hypotension? Well, the main one is hypovolemia. So anyone who has low blood volume from sweating or hemorrhage or any other cause can develop orthostatic hypotension. But also many hypertensive medications disrupt the sympathetic nervous system response to standing, and so they can lead to orthostatic hypotension. The classic group of drugs to do this are the alpha-1 blockers. So one of the main receptors that your sympathetic nervous system uses to raise the blood pressure when you stand are the alpha-1 receptors. They're found in veins and they're found in arterioles. And so when these alpha-1 receptors are blocked, orthostatic hypotension can occur. And then it's also classically associated with ACE inhibitors, especially in patients already on diuretics. So if a patient is taking a loop diuretic like furosemide and has volume depletion, this is going to activate their RAS. So they're going to have high levels of angiotensin II circulating to maintain their blood pressure in the setting of volume depletion. So if you then give an ACE inhibitor and you disrupt the RAS, these patients will sometimes develop what's called first dose hypotension. And it basically means you're giving the ACE inhibitor, you're disrupting the RAS in a patient who's dependent on the RAS because of their diuretic therapy. Reflex tachycardia is another adverse effect that can be seen with many antihypertensive drugs. And the idea here is that drugs that cause peripheral vasodilation lower the blood pressure, which is a good thing if you're treating hypertension, but that can activate the sympathetic nervous system, and this can generate a reflex response through the sympathetic system where the heart rate goes up and also the left ventricular contractility. And some patients will feel this as a sensation of a racing heartbeat after they're taking a hypertensive drug. This usually occurs with drugs that cause peripheral vasodilation, so you can see it with hydralazine or alpha-1 blockers. You can see it with the dihydropyridine type of calcium channel blockers. It can also occur with nitroglycerin, which I talk about in other videos. High yield to know also is that this reflex tachycardia can exacerbate chronic stable angina. So when you activate the sympathetic nervous system, you get a faster heart rate and more contractility of the left ventricle. That raises the demand for oxygen in the heart, and so in a patient who has angina, this can lead to an angina attack. In order to keep this from happening, sometimes these drugs are co-administered with a beta blocker. And the idea is that you use one of these drugs to treat the hypertension and you give the beta blocker to prevent reflex tachycardia from happening. And then I'll finish this video with a couple of slides on how to choose hypertensive drugs in specific clinical scenarios. So in patients who have diabetes, ACE inhibitors are great drugs to use for hypertension because not only do they lower the blood pressure, but there is very good data that they protect the kidneys from diabetic kidney disease. We often give beta blockers to patients with diabetes, but you have to be aware that these drugs can lower the serum glucose. They also mask hypoglycemia. And I talk about all this in the first video on antihypertensive drugs. Hydrochlorothiazide and thiazide diuretics also can slightly increase the glucose level. We still give these drugs to patients with diabetes, but you need to be aware that they can slightly raise the serum glucose. In patients who have hypertension and systolic heart failure, there is a mortality benefit, meaning the patient is less likely to die from systolic heart failure if you give them an ACE inhibitor, a beta blocker, or an aldosterone blocking drug. So these are great drugs for hypertension in patients who have systolic heart failure because of their mortality benefit. Importantly, though, in this group, calcium channel blockers do not have a mortality benefit, and because they decrease contractility, we try to avoid them in patients who have systolic heart failure. If you're asked to choose a drug to treat hypertension in pregnancy, you should be aware that methyldopa has a lot of data showing that it's safe in pregnancy. The problem with methyldopa is it's not very powerful, so it often doesn't lower the blood pressure enough. So other classes of drugs that are used to treat hypertension in pregnancy include beta blockers, nifedipine, and hydralazine. Importantly, though, and it's high yield to know this for your boards, you don't want to prescribe RAS-inhibiting drugs to women who are pregnant. So drugs like ACE inhibitors or ARBs or direct renin inhibitors. And the reason for this is that when you disrupt the RAS in the baby, that can lead to congenital malformations, especially malformations related to the kidneys and the bladder. If you're asked to treat a patient who has hypertension but significant renal failure or hyperkalemia, there are a bunch of drug classes you want to avoid. So first of all, you want to avoid ACE inhibitors and angiotensin receptor blockers, because as I talked about earlier in this video, these drug classes reduce A2 levels and aldosterone levels, and that can lead to higher potassium. You also want to avoid potassium-sparing diuretics because they raise the potassium level. You also want to avoid diuretics in general because they lower the circulating volume, which lowers the glomerular filtration rate, and that can make the renal failure worse. So on a board question, if they ask you to treat hypertension in someone with significant renal failure or hyperkalemia, you usually want to pick one of the calcium channel blockers like nifedipine or beta blockers. These groups of drugs are usually okay in patients who have abnormal kidney function and hyperkalemia. And that concludes our second module on antihypertensive drugs.